Good afternoon and welcome everyone. My name is Robin Buxbaum. I'm the Strategic Partnerships Coordinator here at ACHA. For those of you who attended last week's Q&A session, welcome back. For those who missed it, a recording is available on our ACHA YouTube page. Last week, we asked you what your biggest questions were regarding COVID-19. So many of you told us that telehealth was your top concern. Recognizing this is happening very quickly, we're hoping that our speakers today can give you some useful information about the telehealth regulatory landscape and hopefully shed some insight into how to best implement telehealth on your campus. At any time, feel free to type a question into the questions pane on the right side of your screen. We will have time at the end for Q&A. We may not be able to answer everyone's questions today, and it's possible that we don't even have the answers to your questions yet, but we will do our best to get you answers. One last item, those registered will receive a link to a recording of today's presentation, but it will also be posted on our website and on our YouTube channel. With that said, let's get going. I'm pleased to introduce our four speakers. Mei Wa Kwong is the Executive Director for the Center for Connected Health Policy, the federally designated National Telehealth Policy Resource Center. She has published several articles on telehealth and telehealth policy and is the co-author of CCHP's 50-state Medicaid telehealth reimbursement survey. She is recognized as an expert on telehealth policy and has been consulted by state and federal lawmakers on telehealth legislation. Erica Bumpurs has been a healthcare professional for 20 years, first as an occupational therapist and then in an administrative role in a hospital setting. She joined College Health in 2016 at Sam Houston State University in Huntsville, Texas, and currently serves as the Director of Student Health and Health Promotion there. Dr. Michael Deichen is the Associate Vice President of the University of Central Florida Student Health Services, where he has been for over 17 years and where he oversees the health of almost 70,000 students. Dr. Deichen is active in ACHA, serving on the current COVID-19 task force, the Emerging Public Health Threats Task Force, and the Foundation's Vaccine Survey Project. Our last speaker today will be Dr. Jun Mitsumoto. Dr. Mitsumoto is a family doctor and the Associate Medical Director of Primary Care at the NYU Student Health Center. He comes from a background in community healthcare for the underserved and is relatively new to college health. His interests lie in the use of new technologies to increase access to healthcare services and improve the experience of medical care. His current focuses are point-of-care ultrasound in primary care and telemedicine for improving the in-person visit experience. So first, I'm going to turn it over to Dr. Deichen to set the stage a bit about telehealth and the unique place college health finds itself in right now.
Thank you, Robin. And I want to thank Devin Jopp and his team at ACHA, as well as all the ACHA leadership for the great work they've done in helping us to respond to the COVID-19 pandemic. It's really been exceptional. And I also have a shout out for Jean Chen, who is chairing our COVID-19 task force. It's just been marvelous to work with her, and she's such a resource for ACHA. So this question, why not telehealth, has been a pervasive question at my university for at least the past several years, and I suspect a lot of our listeners have wondered about that all as well. In small part, we satisfied this interest by our students and the community by adopting telehealth with our SHIP plan about 2 years ago. Interestingly, last fall we did a 5-year strategic plan, and in that strategic plan was a goal to begin to expand telehealth. You know, like many of you, I never imagined that here in March we'd be faced with a highly contagious disease, limited PPE and resources, no vaccine or effective treatment, and students that were off campus and needed care. You know, they say that necessity is the mother of invention, and truly this is a time for telehealth. Telehealth helps us to maintain the social distance. It helps us to reduce the risk of unnecessary exposure, improves the accessibility for our students. It delivers messaging and programming, and it helps the providers to stay safe, maintain that social distance, that physical distance between them and the patient, and still being able to deliver care. So telehealth has been something that at UCF, we've rapidly marched down that path and are now utilizing for all our patients. And Robin, you can move to the next screen.
So next up, thank you, Dr. Deichen, first of all. Now let's move on to Mei Wa Kwong, who will give us a big picture view of telehealth and the regulatory landscape. Mei?
Thank you, Robin. And as Robin said, this will be a big picture view, more like a 28,000 foot level view of things, because the policies before COVID-19 around telehealth were pretty complicated and diverse when you went from federal to state. And now in the COVID-19 environment, they become even more complicated because it's moving so rapidly. So I'm going to go through the first couple of slides fairly quickly and then try to get to the heart of things. First off, disclaimers. I do have to say that the information provided in today's talk is just for informational purposes. It is not to be considered legal advice. If you are looking for a legal opinion, please seek out legal counsel. Also, if I happen to mention or show a product or a company, know that neither I nor CCHP have any type of financial arrangement with them. Next slide, please. So these are just a little bit of background of CCHP that I think we can go forward, skip through just in the interest of time. Next slide. Next slide. I do want to pause on this slide for a moment to let you know that there are other resources available for you. Robin mentioned in my introduction that I am the federally designated National Telehealth Policy Resource Center. I work with 13 other telehealth resource centers who are also federally funded to provide technical assistance on telehealth. So there are 12 regional resource centers that cover specific states and another national center that covers technology questions, and we all work collaboratively together. So they are a good resource for you to also engage with for some of your telehealth questions, especially if you are trying to start a telehealth program. That is what the regional resource centers are there for, to help with that program operational level questions as well. Next slide, please. One thing we do as the National Center on Policy is that we do track all of the telehealth policies for all 50 states and on the federal level. This is a snapshot of our website. So if you are located or interested in a particular state, you can click on that state and I'll bring up all the information related to Medicaid policies, the laws and regulations for that particular state. Next slide. So I'm going to guess most of you are familiar with this, so I won't spend a lot of time, but there are 3 modalities for telehealth. The live video one, storm forward, which is capture of information that's being sent over a secured system, and the remote patient monitoring, which is continuous monitoring. I'm going to guess, especially in this very sort of accelerated crisis period, that probably most of you are looking more towards the live video modality, but I just wanted to make you aware that there are 2 other modalities underneath telehealth that can be used to provide services. Next slide, please. So this is really more of the regional telehealth resource center's domain and like how we actually like to walk people through when they're interested in starting a telehealth program. However, not only in interest of time for this particular presentation, but also that probably many of you are trying to ramp something up fairly quickly. We can't go through the entire process. So I pulled out a couple of things for you to consider where you might want to ask questions for where you're starting. It's first off, figure out what services you'll be providing, because probably not all of you will be providing the same type of services. Perhaps, you know, one institution is only interested in providing mental and behavioral health services, another is perhaps providing more primary care services. But figure those things out, because that will also dictate to you what type of technology you might want to use, and also how some of the policies work with you, because some of the way the policies are structured is around the services that you provide, who's providing those services as far as who the provider is, and also around the modality that you're using as well. And then figure out what you have on hand. The most important thing is to understand what connectivity that you have in like connecting with the student who I'm gonna assume is probably going to be at home. So is there a way for you to have like that secure connection with them? And also, what is the equipment at both ends? What are they using to connect with you back to the student health center? And then be aware of what are the policies that you need to be aware of. Reimbursement is obviously something that is going to impact this, but also licensure, other policies around telehealth specifically, such as malpractice coverage and informed consent, and we'll get into those a little bit later. But that too will also influence how you structure your telehealth program and also this type of services that you'll be offering. And then make sure you have policies and protocols in place. Again, we are in a crisis situation, and I know some of you have probably heard things such as, oh, the federal government has waived licensure laws, or they've like waived HIPAA requirements. But you still want to have some of those policies and procedures in place, not only to protect, health information, protect you, but also other policies in place to know what to do if something does go wrong. Like, what if the connection breaks down during a session, or, what happens, if you're doing a mental and behavioral health session and, it's going in a way where you would feel more comfortable if there was somebody there with the patient when you're engaged with them. So having those protocols in place will really benefit you in the long run and help your telehealth program run a little bit more smoothly. Next slide, please. So these are just a list of resources to help you get started. There's the CCHP website. All the TRCs are building sort of like a starting landing page for dealing with COVID-19 and where do I get started. Mid-Atlantic is just one example. They have a terrific page asking all of those really, frequently asked questions, beginning questions of like, what to do, how do I get started, what are some of the issues I need to look at, and also, of course, the consortium website itself. The consortium website is a way for you to get to your appropriate telehealth resource center that covers your region. So those are just some resources I wanted to put there for you. Next slide, please. Now getting into the policy. So some of you have probably heard that things have been moving pretty rapidly around telehealth policies, and they have been. I am not going to cover the changes that are in Medicare. That's gotten a lot of attention, but in speaking with Robin, my understanding is probably not policy that's going to impact the patients that you guys deal with on a typical day. So we're going to look at other policies and then look a little bit more deeply into the states. So HIPAA, but this is something that could impact you. Some of you may have heard that the federal government were relaxing HIPAA standards. So what they have says, the Office of Civil Rights said that they will exercise enforcement discretion and waive penalties for HIPAA violations. Now, the thing is, though, is that you still need to be aware of what the states are doing. A lot of times, HIPAA is kind of the floor for what's required. States may actually have more stringent guidelines on like how health information is protected. And keep in mind, especially since I'm thinking probably a lot of you are crossing state lines and you're dealing with patients who are located in other states, it's going to be the laws and regulations in that patient's state that matters, and not necessarily the ones that you're probably more familiar with the state that you're actually located or the provider's actually located in. Now, what some states are doing is they are looking at like relaxing some of their standards themselves within their state. A lot of that probably has been more with areas they have control over, such as maybe they're relaxing some of the privacy standards in Medicaid initially, and then things that are in statute, they're probably assessing that right now. But it's going to vary from state to state and like how far they go with that. So keep that in mind, that it needs to be, you need to understand what's going on in the patient state as far as like the protection around health information. Next slide, please. Licensure. Again, probably heard something about licensure on the national level being waived. So I think what they were trying to get at is that it was in relation to Medicare, because there are some requirements in Medicare where they require, in order for a provider to get reimbursed if they're providing services to the patient, they need to be licensed in the patient state. And I think they were getting at like relaxing that. And also recently I just heard that the Health and Human Services Secretary, Secretary Azar, sent out a letter encouraging states to relax licensure laws because licensure is actually in the state domain. It's not it's not something the feds have control over. So it is, again, up to each individual state and how they address licensure and what they are willing to relax or not relax. Like with HIPAA and health information protections, some states are issuing or allowing a little bit of relaxure in the licensure. Again, it may be easier for them to do that in the Medicaid program and trying to relax some of those requirements. So it's going to vary from state to state, and it might kind of vary from payer to payer what they require as well. So that, again, is up to individual states and what they're doing too. Next slide, please. Other federal moves that have happened that are outside of Medicare that I think may also have application here. So for prescribing a controlled substance, that using telehealth, that is actually under federal control there. That is, the feds do have control over that and how you prescribe a controlled substance when you're using telemedicine. And when they look at that, that means that the prescriber is using telemedicine and they've never seen the patient in person before. And there's about 7 exceptions on how you can do that with telemedicine, and they're very narrow. But one of them is when a public health emergency has been declared and is in effect. So that has kicked in and allowed a little bit loosening of like when you can prescribe. It's basically has to be for the DEA. It has to be when it's for a legitimate purpose. You have to do it over live video, and that you're acting in accordance with federal and state law, applicable federal and state law. So this is a little bit looser, and it could have, application to what you all are trying to do as well. So I wanted to put this here too. But keep in mind, looking at that third bullet, it's saying state law again. So you have to again understand what the state law is around prescribing when you're using telehealth and prescribing controlled substances, because again, some states have probably things on their books. I do know that they do have things on their books regarding prescribing a controlled substance that may be a little bit more stringent than what was in the federal law as well. So again, something to keep in mind. And this is one area that I don't think I've seen anybody yet, but I haven't dug through all of the state sort of guidances and executive orders, but it wasn't one that was popping out immediately as an area where they thought to relax some of those holds. So again, the feds may have loosened things a little bit, but you could still run into state policy issues as well. Next slide, please. So what are the states doing? So pre-COVID-19, in the Medicaid program, at least for fee-for-service, everybody was doing something related to live video. The other modalities were a little less popular. However, there's usually like a lot of restrictions in with their policies, such as, the type of provider who can provide the service, where the patient is located, and, the modality that you can use given the information here. Next slide, please. What states also have are what are called private payer laws, what they tell insurance companies that they can do related to telehealth. And again, they run the gamut. They run from, states that say, oh, health plan, you can't cover services if they're delivered via telehealth. There's nothing against the law to do that, all the way to health plan, you will cover these services regardless if it was done via telehealth or in person. And by the way, you'll pay the same amount. So you have those also influencing things, probably influencing some of the population that you're dealing with if they're being covered by some sort of private insurance, like through their parents or something that they purchase, as opposed to like Medicaid. Next slide, please. So in a COVID-19 world, what are states doing? A lot of them are relaxing some of those Medicaid policies and allowing more expansive use of telehealth to provide services. So that's a good thing, but not all states are doing that, and not all of them are relaxing things in the same way. Some states have to take more action than others because pre-COVID-19, they may have had more narrow policies, whereas another state had like more broad policies, so they didn't have to take as many actions. They may not be only doing like widespread actions, but they may be saying like, we'll allow certain locations for you that become eligible for you to receive a telehealth services. Again, and I talked about this earlier, licensure waivers. Some of them are looking at doing that, relaxing those restrictions. But a couple other areas where they are doing things that could impact telehealth is allowing services to be done by phone. Now, what you'll see in a lot of emergency waivers and declarations coming from states is that they'll say something like telehealth and telephone and allowing that. And that's because practically all states, I can't 100% say all of them, but it's like most of them have said in their definition for telehealth that it does not include the phone. So that is why you see them saying telehealth and phone, because if they just said telehealth, phone would not be included, and they're trying to expand the access points as much as possible. And for some people, phone may be the only way. We're also seeing like waiving of copays and deductibles, or like not charging as much for these services. And then people or states are making changes through their 1135 waivers to have the feds relax some of the requirements that they have around like how they can provide services where it might butt against trying to use telehealth more. Next slide, please. So a couple of issues that you guys need to be aware of. And again, this is 28,000 feet, and also it's varying from state to state. So it's going to depend on like what state you're talking about. And I know this is going to be really complicated because probably a lot of you are dealing with students who are in a numerous amount of states. It's not just one or two. So reimbursement, it's going to depend on what the payer policy is. So whether it's Medicaid or private payer, it can vary widely on what they will allow and what they will do. A lot of times around reimbursement, you're going to see restrictions on like the modality that can be used, who the provider is that's going to be reimbursed, the type of services that they will reimburse, and the location of the patient. And for this particular issue, the location of the patient probably is one of the killer things for you, because I'm guessing for a lot of you guys, your patient, your student is probably going to be located in the home when the telehealth interaction takes place. Pre-COVID-19, a lot of the Medicaid programs, at least, and some of the insurers would not pay for a service if it took place when the patient was at home. They usually had to be in some sort of clinical setting. That's being relaxed, but not everybody is doing that. So that's probably going to be the biggest hurdle you're going to see with like reimbursement on there is, well, A, if they cover telehealth, B, are they going to allow the home to be an eligible site? And then you go down through the thing of like, will they cover this particular service? Will they cover this particular provider, etc. Consent. A lot of states have some sort of consent requirement on their books, and where they're saying if you're doing telehealth, you've got to get consent from your patient. Usually not a lot of details on that, such as like, well, how do you do that? Do you need to have X, Y, and Z in the consent form? Do you need to do it every year? It just usually says get consent. It's more of an administrative thing to be aware of to do. It's not usually like a big hurdle to overcome, but it is there, and I want to make you aware of it. Malpractice coverage. Actually, not quite sure how this works for your student health centers, but malpractice coverage has been an issue for telehealth providers when they're crossing state lines, because your malpractice coverage may not work in this other state that you're going into. So depending on how that works for you guys, you might want to check your malpractice coverage to see, A, does it cover a telehealth delivered service, and B, will it work in the state that you're trying to go into to provide that service. And then finally, regulatory boards. So beyond the laws, beyond the policies of the type of payer that you're using, regulatory boards, licensing boards sometimes have additional requirements on their licensees and what they expect them to do when they're using telehealth. So that is something to also be aware of whether, there's like additional requirements. For the most part, they usually don't, but sometimes, a state might throw in something quirky in that, oh, you need to make sure that the patient is aware of your credentials or something like that. So just be aware of those things. Like I said, for the most part, they're not asking anything onerous. It's usually like you agree to use the same standard that you would if you'd done it in person, but just double check on those as well. Next slide. And just some more links to information if you guys need them. And I think that's it. So we'll stop there.
Thank you. And May, before we move on, I do want to let everyone know that ACHA is working with the American Council on Education and other leading higher ed associations on a letter to all 50 governors urging interstate licensure relief. And that's expected to go out next week. So I just wanted to let everyone know that we're doing as much as we can to help the licensure situation. All right, we're going to move on now to hearing about how schools are putting telehealth into practice and how their experiences might help you. Erica?
Hi, yes, thank you, Robin. Okay, so as it was said in my introduction, I am Director of Student Health Services at Sam Houston State University in Texas. And I was asked to be on this webinar by Dr. Huey, who was part of our AAHC survey. So he knew that we already were providing telehealth services prior to COVID and prior to needing to really put that in place quickly. We started at Sam Houston State University in 2017 in that fall semester with our first telehealth service being our psychiatry service. And we did this really out of necessity. We were having challenges hiring a psychiatrist. We're in a fairly rural area, and so we did not have a lot of access to psychiatry services for our students. So I was charged with going down the path of seeing if we could contract for telehealth for psychiatry. And so I wanted to give a little bit of background on that. At that time, we did have the luxury of really researching and looking at putting a lot of the things in place that Mei talked about to implement kind of on a slow pace and get it going well and under regulatory guidelines. But as we came into the need of needing to turn this on very quickly in our medical clinic, that experience certainly helped us to be able to turn that on without a lot of background information needing to be researched first. So some of the interesting things about our first round of telehealth with our psychiatry is that the psychiatrist is actually the one that was working and still is working remotely for us. So in our setup, the students that were coming in for the psychiatry service, we were having them at that time come actually into the student health center, into a room that we set up, and they were connecting them with the psychiatrist who was remote from our building. We have had several psychiatrists in this service along the way, and several that actually were not located in Texas, but as Mei mentioned, these were psychiatrists that were licensed to practice in the state of Texas, so they were working for us in that capacity. The platform that we chose to use is Doxy.me or DoxyMe, and we have used that since 2017, are still using that. And that is a service that we used to implement when we went to telehealth in our medical clinic a couple of weeks ago. And so as she talked about policies and procedures and consents, for our psychiatry service, we did do some specific building of, especially with our consents, we actually have two consents. So the student is not only consenting to the service and the psychiatry service, we have a separate standalone consent that is strictly consenting to getting their service through telehealth and talks about some of the technical and other issues that can happen. So we wanted to make sure that we were consenting on both sides and covering all that ground. For us, equipment needed, I think that's one of the really nice things about telehealth is equipment needed is minimal. In our first setup in this room, we simply have 2 monitors, so we have double screens that we're utilizing, and then we did install an external microphone that's on the desk because we found through trial and error that sometimes the microphone and the communication through the computer itself was not as clear as we would like it to be, so we invested in that additional piece of equipment. But outside of that, there was really no other investments. The DoxyMe platform, if you use their basic version, which has worked well for us for the last almost 3 years now, is completely free. So we did not have to invest in any type of service to be able to do this. Staffing, as I mentioned, our providers are off-site, but we do have a medical assistant who is dedicated to the service on-site. And I'll talk about this in some of my lessons learned. What we learned about some of the challenges and the needs for supporting a provider who is off-site from us trying to deliver this service in coordinated care with our current on-site staff. Prescribing is something that Mei mentioned. And again, in my lessons learned, I'll talk a little bit about what we learned about e-prescribing and specifically prescribing for psychiatry services. And then we did ensure both with our original psychiatry telehealth, and we went back and double checked this recently for our clinic side with our medical liability and malpractice insurance, that the product that we were using, the company that we were using, does offer coverage for telehealth in their service, so that we had assurance that we had that coverage when we were practicing in that way. Next slide, please, Robin. So lessons learned, and these were lessons learned before COVID-19. So this is just when we first implemented our psychiatry service. We certainly learned and are continuing to learn that it is more difficult for an offsite provider to feel supported. We have psychiatrists that are practicing in other states and other locations in the state of Texas, and they never really have had the benefit of being in our facility and really even just seeing our patient flow, our workflow, how we're delivering services. So we've had some growing pains along the way, integrating them in that way and knowing that we really needed to give them a stronger support service because they are not right there with us. As far as our psychiatry service, we've had a few challenges as far as prescribing because we currently do not have EPCS, so electronic prescribing of controlled substances set up. So we've actually had to do some mailing and other ways of getting those prescriptions filled. And then the auxiliary support. So I mentioned that we originally, the MA that we had assigned to this clinic, it's not a full-time clinic. So we're doing psychiatry a couple of days a week. And so she was only dedicated to that service on those days, kind of when we were open for business and operational. But we've learned over time that when you are doing telehealth services, and we've even seen this now that we've implemented it in our medical clinic, the support level for not just the provider, but the patient or student that we're seeing is a little bit more demanding, because I think when you don't have that, in-person, face-to-face, and they're accessing everything on site, there's a lot more questions and a lot more follow-up and things that need to happen. So we actually have transitioned to where that support for this service is available 5 days a week, even though that particular service is not running 5 days a week. Crisis situations, and I think this applies both to our psychiatry, and even now as the COVID is it's developing and there's a lot of questions and a lot of concerns. Crisis situations or uncertainties or having a lot of questions can feel uncomfortable, probably on both sides for the patient and the provider in telehealth. So I think that's just something to be aware of, to know that one of the things that I've observed as my providers are doing telehealth is that it does take a lot of energy, and I think a heightened level of energy to deliver this service in this way. It's not as easy, it's not as comfortable. So we want to be aware of that and make sure that they have the support that they need in that regard as well. And then just a lot of frequent communication. In our psychiatry clinic specifically, the providers and our MA, as they're communicating throughout the day and while clinic is going on, are messaging each other via text or instant message, really about operational and logistic things, certainly not about patient things, but just, checking in and how are things going and is the next patient ready. So when you're not in the same place, we found that just constant ability to communicate has been very important. Next slide, please. So our transition. So we transitioned, I would say, fairly rapidly within a couple of days, about 2 weeks ago, to flip our medical clinic practices, and I say primarily to telehealth. And I'll talk about some scenarios as I go through this. We are not currently doing only telehealth, but primarily, yes, we are trying to talk with and provide services to as many students as possible without them actually coming into the clinic. One of the things that may or may not be unique to our campus is that as of even still today, while our instructional and curriculum delivery is online platforms, our residence halls are still open. Other areas on our campus are still open, so we do still have students on campus. So we are talking with students both that are remote, maybe off campus, but still in our city. We're providing services to students who may have gone back home, so outside of our city, even other states. And we're still providing services to our students that are on our campus and may still come into our clinic for a visit based on our telehealth and our triage of that. But some of the main changes that we made in our medical clinic, our front desk operations have drastically changed, where our front desk used to be the ones taking all the phone calls, finding out what the students' needs were, scheduling their appointment. We have shifted that process, and we actually were doing a lot of online scheduling prior to this transition. I've turned that off because we do want to talk to every student to find out more information before we decide what route we're going to take. So currently, our students cannot online schedule anymore. But what our front desk is doing is they're taking that initial call. They are getting the students' demographic information, verifying a best number to call back, and simply asking, what is your reason for visit? Why are you needing to come in? So they are not doing any health screening or any what we would call of our COVID screening questions at that point of contact. The other thing that the front desk is doing is, so then they're advising the student, a nurse will be calling you back to discuss your symptoms, determine what visit option we're going to use. And then as far as the consents, when we went to telehealth, I moved all of our consents to our patient portal so that students, wherever they're calling from, can go ahead and log into their patient portal. Our front desk staff is telling them while they're on the phone, let's go ahead and do this in case they need to walk them through it. And one of them told me last week that what they're using is to kind of incentivize the student is to say, we have to get this done before the nurse can even call you back. So we're really being proactive about getting those consents done up front. And so once that information is obtained and the front desk lets the student know a nurse is going to call them back, our nurse is then the one who makes an additional phone call back to the student. The first thing they're doing is again confirming that they've completed their consent so we can have this visit via telehealth. And then they're doing an intake and COVID screen, and in a future slide you'll see those questions that we're asking. And then they're informing the student of how they're going to log into their telehealth session. So with DoxyMe, it's essentially a waiting room. So each provider has their own DoxyMe clinic waiting room. And we're simply, with this service, you simply give the student a web address to that provider's waiting room, and the student just logs in via their computer. Once they're in the room, the student hits check in so that the provider can see that the student is there. But another thing that I really like about DoxyMe is that the provider has the control on their end. So they see that the student's there, and then when they're ready to start the visit, they click start visit, and they're controlling when that student comes on their screen to interacting with them. And then the other thing that the nurse is doing is routing that information, the intake information they've taken, to the provider and letting them know that their patient is ready to start the actual telehealth visit. Next slide, please. So at that point, our provider takes over in the telehealth process. So they're already logged in. And then we are doing an additional step where the provider is then going to verbally consent the student that they are agreeable to have this visit via telehealth, and the provider is going to document that in their visit note. And then the provider has some additional assessment questions they're asking, and then they're going to do their general health visit assessment. And at that point, the decision that our providers are making is, can the reason for visit, what the student needs, be fully met via this telehealth visit versus them needing to come in for a clinic visit? And currently where we're looking at that situation is we are trying to only bring people in that really we couldn't complete the full assessment via telehealth, or if we are actually determining that we need to do some testing and potentially do the COVID-19 test, we're bringing them in for that as well. And so some important considerations that we've learned along the way with our psychiatry service and now with our clinic service is that the location of the person doing the telehealth visit is very important. So we're making sure that the student on the other end, or the patient, is seeing, is feeling that it's confidential. So the room, the setting is comfortable, there's not distractions, there's not people walking by in the background. So our providers that are in the clinic doing these visits are doing them in a private office space so that there are not distractions and that we're maintaining that confidentiality. Another thing that we've really had very few challenges with, but it's important to think about, is that especially as now we're having students check into their visits from various locations. It could be their dorm room, it could be home, it could be a home that's in a very rural location. We've had just a few challenges with internet connections, usually on the patient end and signal strength. So we've had to troubleshoot a few of those to make sure that we're having a strong, valuable connection so that that visit can be done appropriately and that we're not having any communication issues. Next slide, please. So this is, I just wanted to share because I thought that the group might be interested in this when I talked about the nurse's role and the kind of the pre-screen that they're doing prior to the telehealth visit. And I will say some of these questions are very specific to our situation that we're dealing with, knowing that we're dealing with students still both on campus and off campus. And also in regards to some of the requirements that our university implemented as far as COVID-19. So I'm not going to read these questions because you can certainly read them, but one of them that I'll point out is one of the quarantine requirements that our university put in place was traveling via any form of public transportation. So that's a question we added in. Have you been participating in any crowd events in the last 2 weeks, just to know kind of if they have been isolating or quarantining versus if they've been out and about a lot. And then we've also learned that we need to ask, have you been working, and if so, where? Because we have had some students that we have interacted with that were student workers still working on campus at areas of our campus that are still open and operational. So we wanted to make sure that we had that information to add into our assessment and make sure that we were covering all our bases as we do this visit. Next screen, please. All right, so I think that's all from me, and I'll pass it back to Robin.
Thank you. Thank you so much, Erica. That was really, really informative. We're going to move on to Dr. Deichen.
Thank you, Robin. And it was interesting listening to Erica. The experience that we're having at UCF is remarkably similar, even though we're using a different product. We're using Zoom for Healthcare. And the reason that we're using Zoom for Healthcare, it just happens to be that that was a contract that already had been established with our medical school at UCF. We're part of the Academic Health Science Center, and we fall under that umbrella. So there was an existing contract with a business associate agreement, which was perfect. Our students also use Zoom for classwork, so they had a familiarity with the product. And so that made it pretty easy for us. Technically, we're doing telemedicine. We have live audiovisual and person-to-person contact between the provider and the patient. We needed to install Zoom application on provider devices in order for this to be facilitated, but that was relatively easy. And we found that it is ideal to have both the audio and visual components available for the provider when they're having this encounter. It's a much richer experience for the provider and probably for the patient too, to have both the audio and visual. Our providers can use one screen, although I have found that, similar to what Erica described, 2 screens and a microphone, an external microphone is the optimum, but they can work with one screen. We found that our schedules for our provider staff are best to have an encounter every half hour. And halfway through the morning sessions, we have a half-hour catch-up time. Then we have our usual administrative time at lunch break. And then the afternoon, there are half-hour appointments with another half-hour catch-up halfway through. You got to realize that this is a new type of service that we're providing, and there are a lot of steps. I just didn't feel comfortable pressuring our providers to work any more quickly. And quite frankly, there are added steps that we've given our providers to achieve this. With that schedule, they've done really well. They're happy with that schedule. Our providers are doing well, keeping up. It's not been an issue. And we found it to be extremely intuitive on the part of our students to engage with telehealth, either from their phone, their iPad, their desktop. They're just amazingly adept at interacting on a telehealth basis. Next slide. So I wanted to walk through the particular steps of our process, and I think that'll be very informative for those of you that aren't using telehealth, and maybe that will help to guide a telehealth procedure that you could set up. So first, there's the patient. The patient calls our health center to make an appointment, and so instead of an appointment being set up at the health center, the appointments clerk asks if they would like to have a telehealth visit. They also screen the complaint. If the complaint or the interest for the visit is to have a physical, for example, the patient is told that we're not able to do physicals at this time, and there's certain other key complaints that we don't think are appropriate for telehealth encounters, and we're therefore deferring them to when we have that capacity. Right now, we're doing all telehealth. We've moved through these various stages of response to the COVID, where at first we were tightly screening all our patients. We were seeing them. We had specific providers that would see someone that was at risk for COVID. We had all the personal protective equipment, and we ran out of one thing after another, masks, gowns, and we realized this just has become very unsafe. And there's so much unknown about the COVID. Is it aerosolized, for example, that we decided together that we would move to a telehealth procedure, and that's the direction we've taken. So after the patient has described their reason and they've accepted that they'll do a telehealth visit, it's very important to clarify what is the preferred email on the part of the patient. Oftentimes within our patient accounts, we have multiple emails that are listed, and for this encounter, it's important that we have the right email listed, because that's going to be the one that we communicate with the patient as setting up the appointment. So after that, it becomes the responsibility of our appointment clerks to take steps to make the telehealth appointment. And it really takes appointment staff that's versatile in working with different products, because we're using our electronic health record, which is eClinical. We're using Outlook, we're using Zoom, we're using Qualtrics as part of this process. And so, fortunately, our appointments staff are young, and this seems like the easiest thing for them, and they're very capable of using multiple systems in the appointment process. So once they have the call and they've clarified the email, the appointments clerk is going to select a time that is designated within our electronic health record, just like they normally would. But then they're going to put an invite through Outlook to the patient email for the Zoom appointment, and then establish the Zoom appointment. And through that, we'll have a meeting ID, password, and patient phone number that will be available on the electronic health record appointment screen, so that when the provider opens his electronic health record, he'll see that at such and such a time there's a patient and what that patient's meeting ID, password, and phone number are. The phone number is really a backup in case there's some difficulty with communication. We also have to get a consent for telehealth, and we have a consent that we vetted with our legal department, and we have a unique process whereby through a QR code, we have the patient download the consent and basically then send back to us via email. And you know, our clerks again have been so ingenious. They color code our appointments so that if it's a red appointment, the consent's not been done. If it's a green appointment, the consent's been done and the patient's ready to go. Next slide, please. So, previous slide. So the provider has some basic steps. Then when they're in their office, and right now we have providers in the clinic in their offices, but we are also moving some of them to home, and it's our goal to move all of them home for a block of time. Orlando's in a shelter-in-place status. We're having significant increases in numbers, so we want to keep them as safe as possible, and we'll probably be moving to that for a 2-week period of time. So they go into the electronic health record, and there they can see the meeting ID and password, and if they're using a single screen, they can have a split screen with Zoom and the EHR, and through Zoom, then they put in the login with University ID, they join the conference and enter the ID and password and enter as the meeting host. And a lot of you have had experience with Zoom, and I think you understand what this means from a phone conference perspective, but this is the way that it works with a telehealth perspective, very, very similar. So the provider, we've asked to confirm the patient name, date of birth, and consent before initiating the interaction. Also, we're asking once the interaction is initiated that the provider confirm with the patient where they are. And why we're doing this is it's possible that the person is not in our locale, they're in Miami, and we want to be aware of that in case we are concerned about the welfare of that person, how to access resources for protection of the individual. Next slide, please. So I'm not getting into all the things that happen when the provider starts that encounter. It's fascinating to be a part of that and to see the utility of the telemedicine encounter. We're handling so many things through telemedicine, and normally we would see 300 to 400 patients per day. We're a large student health center. This time of year, we're having 100 telemed visits per day, but that was achieved without any marketing, with the student population mostly vacated from campus, and the students have really loved it. It's been extremely well accepted by the patients. We found that prescribing is and lab orders are relatively easy through our electronic health record. There are some nuances to the prescribing because our pharmacy is still open, but it's not hard on the part of the provider, but we've had to create various steps for our pharmacy staff with regards to dispensing to keep them safe. The providers do need to start their appointment promptly. As Erica was describing, there's this virtual waiting room, and every half hour, there's a new patient that's scheduled, and it gets difficult if they don't start promptly, and the patient really doesn't know what's going on during that interval of time. We found it useful for our provider staff to have frequent meetings to share best practices. That just accelerated our learning and best practices greatly and has been very useful. We're using the Zoom for Healthcare. The OCR has approved other vendors such as Skype for Business and UpDocs, VC, DoxyMe, like Sam Houston is using, and Google G. And we're using the Zoom for Healthcare for the reasons I described. But our electronic health record does have a telehealth setting that potentially we could have adopted, but we're having issues with our portal, and so that wasn't the way we chose to go. Our appointment staff would have had a much easier time if they'd done telehealth through the portal, but nonetheless, we've made things work. Our appointment staff does need 2 screens. Our providers can get by on 1 with split screen, but just imagine our appointments people are using these multiple modalities, and so 2 screens is necessary. Okay, next slide.
Sorry about that, Dr. Deichen. I didn't mean to rush
No
you.
worries.
We are running out of time, and I don't want to, I want everyone to have the ability to hear Dr. Mitsumoto. So we're going to move on, and we're probably going to run out of time before we get to questions, but I do want to let everyone know that we're going to take all these questions and try and address them in our FAQ document on the ACHA website. Dr. Mitsumoto?
Yes. Hello, everyone. And just wanted to, quick thank you to ACHA for this opportunity. And also thank you to Mei Wa, Michael, and Erica. I mean, the reality is, with time sort of running out, I think they did an excellent review generally of how to put these kinds of telehealth systems and workflows into practice. Our overall workflow is very, very similar to what Michael just went over. So if anything, I could really just talk about briefly from here in the epicenter of the COVID pandemic in the United States at this time. In some ways, depending on where you're listening from, I'm speaking to you from your potential future. And I would just say that the move for us to a telemedicine system throughout our critical health services and our entire counseling division really has been an absolutely necessary and truly important move for us. It allows us to continue to engage with our students to get things that they need to address their medical concerns. We do have a limited on-site staff to address things on-site for our New York area students. And really this has been from the beginning just about crisis prevention and mitigation. It was just this sort of weird sort of impending feeling in early March, which has now fully sort of manifested itself to what it is now. And so for those of you who are listening who have those questions about, well, how did you do this? How did you implement those things? How did you address all of those legal issues, the human resources barriers? My answer is, well, we did it as best we could in the moment, and we continue to do it while we see students for these visits actively now. And the reality is that the rollout was kind of messy, it was urgent, and we kept the primary sort of mission and objective in mind, which was to protect our students, protect ourselves, and it's very doable. So for wherever you are, I'm happy to communicate with you further and just sort of what that process is like. But I would advocate that if this is something that you feel like you might need and that you have the ability to put in place, to really push hard to get those systems up and running, to have those discussions early on, because it really has been a truly sort of like life-saving measure for our students in our city here in New York. Thank you.
Thank you, Dr. Mitsumoto. Maybe I could, we do have quite a few questions, but maybe one of the questions that you could answer is what's been the student response to telehealth, and has there been a difference between telecounseling and telemedicine?
Sure. I mean, the overwhelming response has been extremely positive. People are all holed up in their apartments and in the dorm rooms. There's really nothing to do except for maybe go out and get a jog every now and then. So anxiety and stress levels are high. I think for all of those students who have existing mental health concerns, the ability to continue their treatment or to reach out and speak to our counselors has been, really important for them. We have done, according to our most recent numbers, about 952 visits as of Thursday. 2/3 of those were in counseling and a third in medical, roughly. And everyone has just said, well, I'm just glad that you're there. I'm glad that there's someone to speak to help me with my issues. Certainly, some of them are related to COVID-like symptoms, and they just want, again, reassurance. At this point, there's 1,000 websites that you can go to that'll tell you what to do, but there is a difference in just speaking to someone live and really getting your individual concerns addressed. So also the students themselves have really found a lot of sort of positive sort of emotional support from this service.
Thank you. Maybe one last question. Are there specific complaints that you just are not addressing now, and how are you handling those?
Yeah, so we're a little bit different from the traditional sort of virtual care system. I mean, we were originally looking at our sort of sister institution, NYU Langone, who has a virtual urgent care system, and they have a very distinct list of things, they do take care of, they don't take care of. If you have stroke symptoms, please don't log on online for those. We are trying to be a little bit more open. The students can make appointments directly in our PNC portal, so there's really no pre-screening aside from some questionnaires and things that they do. So they get pretty much direct access to our providers. And my mandate to my team on medical really has been sort of listen to the need and help coordinate a plan. So if they are out of state and they need to seek some other local provider, but the student is really unsure, I think that's why they're reaching out to us. Our goal is really to coordinate that for them and to make it clear what it is that they need to do next. So obviously, we don't want true emergencies coming through this system, but really everything else that a student is concerned about that wants to sort of discuss, we're open to that. So, less of like a traditional virtual care, but more even of a care management system for the students at this time.
Okay, thank you. We're going to stay on for a few extra minutes if anyone is able to stay on. I'm not sure who wants to answer this, maybe Dr. Deichen. Is there a need for a separate telehealth consent?
I think Mei Wa Kwong did suggest that it's good practice. And we've chosen to have a separate telehealth consent. I don't understand necessarily the legal necessity, but like so many things that we do in the clinical arena, it is special. It's a unique encounter. And so I think it's very wise, at the very least, to have a telehealth consent. And it's not that hard to achieve that. I think it's a best practice.
This is May. So for most of the states that do have something on their statute or within their Medicaid policies, they do require a specific consent to the use of telehealth. However, they don't cite parameters in that it needs to be a separate consent form or details like that. So what some telehealth providers have done is that they've included it with other consent forms in that, they've listed something in there that telehealth may be used. And in one of the practices that they do, I know with some clinics and some other hospitals, is that they make sure that's renewed every year just to keep that consent like on record, as that they're aware, the patient's aware of it, and that they've done it like every year and they've agreed to it every year. So those are some of the things that people have done to address, because usually the policies are pretty vague, just that you need to have it, but not how to get it.
Okay, thank you for clarifying. This is kind of a big one, and I'm not sure who wants to take this. If students are not on campus and are at home, how does our responsibility change in their care?
I'll try that one. I don't think it is changed whatsoever. For us, we're a state university system. Our students have paid a health fee for the semester. I feel an obligation to provide a resource for them, whether they're at home or on campus. And with telehealth, that's especially easy. It wouldn't be easy otherwise, naturally, but with telehealth, that's something easy. I think each institution has a little different situation, but for us, with the health fee, I feel an obligation to provide that service.
Yeah, I would just, from NYU say the same thing. And I think my providers have been informed, and we've been working on really just trying to set those expectations early on. Certainly, we verify location of the student at the beginning of the visit. And as an international university, and because we have a system that's pretty much open to everybody, we have students who are even international, which goes beyond the issue of state lines. And at that point, really, we say, we can't do a full visit, but I can talk to you about what's going on, and I can give you the best possible advice for your situation. So I do think, we try to help the best we can.
Thank you. Unfortunately, we are at the end of our time today. I know there are still a lot of unanswered questions. And as we get more clarity on some of these issues, we may host another telehealth Q&A. Like I mentioned, we'll also try and incorporate some of these into our FAQ document that is available on the ACHA COVID-19 webpage. ACHA Connect is always there if you want to ask your colleagues a specific question. I've seen a lot of great sharing going on this week. We are currently planning next week's Q&A discussion around the topic of mental health, so keep your eyes open for that announcement. And lastly, a big thanks to our guest speakers today. We know everyone is stretched thin right now, so we truly appreciate your time. Thanks, everyone. Stay safe out there.